And I mean, my experience has been there's tremendous amounts of waste in every organization. The best companies, the best organizations have lots of waste. And the way that you uncover the waste and the way you eliminate it is to focus on the value you're delivering. It sounds like in the medical arena, in addition to the normal amounts of waste that you have in any organization, you have this added dimension of waste of
The biggest waste generator in the system is the physician's pen.
There you go.
Because I write the orders. And I write orders because everybody's different. And I write orders because some days I'm incredibly busy and don't remember if I did the correct thing for this individual or that individual. Sometimes I write orders because the patient insists I write for that drug.
Okay.
And no matter how much I argue with my patient, and no matter how I know that information, and no matter where they've gotten their information from, it's fruitless for me to continue to argue with my patient because they've requested that drug and they have their mindset on that drug. That happened in my office today, despite a 20-minute discussion on the fact that Lipitor is a better drug. I gave her another drug because she was sure Lipitor wouldn't work, and she was not going to accept a Lipitor prescription from me today.
So you have that type of waste, but you also have the waste that we see because of bureaucracies and insurance coding, and I mean, there's very little about. There was a time where referrals had to be issued, and there was all that wasted time in the physician's office and in the insurance company trying to track who had a referral, who didn't have a referral, et cetera, et cetera. When you look at it, you have insurance claims against physicians, sometimes frivolous, which drive the cost of malpractice insurance. So you have all these different waste factors. I guess what I'm not clear about is what percentage of the waste we could realistically eliminate and how we go about doing that. Now, the only point I know where it's being tried right now is in the Health and Hospital Corporation in New York, where they're in the middle of a 5-year program to eliminate billions of dollars in waste in New York City's healthcare system. But anybody familiar with that kind of an effort and what it's likely to do here?
Just there's another piece here of we talk about waste on often referred to or implied on the utilization side, and it comes from your friend, in all respect, Ronald Reagan, in the mid-1980s, and it was an attempt to redefine the payment mechanisms for medical services to be on a competitive basis. And by putting them on a competitive basis would reduce waste in the system. And that was the introduction of DRGs and in large part the acceleration of fee-for-service medicine. For the most part, what we have is a system that rewards for use. A lot of smart people in this system, a lot of smart people who can follow that incentive basis. One way, perhaps, very difficult, Everett referred to it earlier, one way is to talk about capitation, and that's paying for services for a population as opposed to the application of particular modalities or services.
There are also studies that show systems like the Mayo Clinic, which is a fully integrated multi-specialty clinic, actually provide better outcomes at lower cost. And it really sort of defies the common thinking about the cost of care generating better outcomes. Because what you see is that their quality indicators are among the highest in the nation, and yet their costs per capita for treating their Medicare patients are among the lowest. And a lot of what happens within the confines of the Mayo Clinic is good communication among physicians. They're working as a team, they're dealing with the patient as a whole individual, and they're really generating better outcomes. So there's a lot of initiative out there to look at places like that to determine why they're generating so much better outcome at a lower cost.
They're also doing that at Cleveland Clinic, they're doing it at Mayo, and they're doing it down at Leahy.
Right.
It's nice to have someone who acts as your quarterback and the person who then synthesizes all of that information that's coming into them and says, I think we should pursue this, and maybe we should hold back on that. So that's where I think the healthcare delivery system is letting us down.
Absolutely. My office does in fact have 3 employees that do that work, Everett. Down at the clinic, there are 5 or 6 people who act as ancillary to the physician or the clinician who's working down there. But it's an incredibly holistic system, and we can do things down there I simply can't do in my office, despite all the money that the insurance company in the world will give.
But may I, did you see the difference as to why that person came in and said, I don't want Lipitor? That's going back to the pharmaceutical companies and their advertising.
That's correct.
I
The
can
drug
do
she
it better
wanted is
than
heavily
that. So
advertised.
who are they
on the
listening to? Somebody's in bed with the pharmaceutical companies. I wonder what that company is. What's that function of government? What is it, the FD? And now they're going to take on tobacco?
Well,
Fantastic.
in
They're
fact,
doing
it
such
may
a
be
great
the
job
ANA
of FIOS.
too, as we find that journal articles aren't quite as well refereed as they should have
You
been
think?
in the last few years. So
You
I'm
think?
afraid that I can't blame the
And
FDA
it discredits the whole system.
It does.
And when you look at the bill that's being promulgated with 40 caveats, I mean, Kennedy got it out of committee and put it to the floor. Now what are they going to do with the 40? Are we going to discuss that ad nauseum? Or are we going to agree? Or will we ever agree on those 40 pieces that have to be put together either in the Senate or at the House? Do you see what I mean?
I do.
And Churchill came back and said, if you want something not to finalize, give it to a committee. And that's where we're going. Give it to a committee.
In the back, Susan.
Yeah, Sue Kepner, I happen to be a state representative from Hampton, but I live here too, and I'm interested in the healthcare issues. I wanted to pick up a little bit on what Chris said, the prevention, wellness, and all that kind of stuff, and how people need to know that. And I was going to dump it all in education, but it's not fair. But it's a good place because I think we have minds that are still malleable in the earlier grades, and I know that there are some schools doing that. And I think it would be a great idea to, if we could get rid of this No Child Left Behind that's strangling us, and be able to use more of our other thoughts about getting good thoughts into kids' minds early in teaching them more about health and connecting it into the curriculum with science and whatever, and feed them good foods. I think our Hampton's doing a fairly good job with that as far as the food in the cafeterias and stuff. The other thing that I was kind of interested in is a comment from the panel there. Is there any difference in what's called for non-profit hospitals and the profit hospitals and the kind of care they're giving, and whether they're saving any money or cost less to use their facilities?
My impression is that there's huge variation. I don't think that you can say across the board that not-for-profit hospitals are cheaper or less costly to the system than for-profit hospitals. I think it depends on the community and the ethic in the community. But I don't know. Yeah. Anybody else want to?
You've heard of these studies of different cities. I actually did one when I was on the board of Martins Point, which is military retirees. And I looked at all kinds of social factors and what might drive utilization. I didn't look at cost, I looked at number of outpatient procedures, doctor's visits, hospital days. Throughout everything you may think, it really came down to, now they have an HMO model, was their primary care, what was the system their primary care doctor was in? 2 systems out of the 8 or 9 that I had an update on stood out where more was going to happen to you. One was for-profit, one was not-for-profit. All the rest were not-for-profit, and they were all pretty much the same. And there were another couple of profits in there. So I don't think you can say, I agree with Wendy, I don't think you can separate on a profit, not-for-profit basis.
It's not by, it's really not by tax status, which is what the not-for-profit versus for-profit definition is. It's really what the values of whatever that organization are, period. And they can exist in a not-for-profit structure or for-profit structure or not exist in either one.